Hello, welcome to Pathagonia. This is Jay. Happy holidays. It's almost the new year, 2024. I hope you have a new year goal of learning as much pathology as possible. That's my goal, at least. Before we begin, we're going to use Kurt's notes, but check out his website if you already haven't. It's got great resources for med students, residents, and staff alike. There's an About Me page just about to learn about the one and only Dr. Shapard. There are quizzes, as well as useful links and articles to help consolidate our learning on pathology. So, GI infections. Let's talk about bacteria first. H. pylori, gram-negative, slender-curved rods infects around half of the world's population, more commonly in the underdeveloped countries through person-to-person contact. Acute infection, histologically, you'll see this chronic active gastritis with a superficial lymphoplasmacytic infiltrate. I say superficial because if it's deep, you want to think about, and if the mucosa looks all antrum, you want to think about AMAG. It's more prevalent in the antrum, and you'll have often erosions and germinal center formation, and it can lead to MALT lymphoma, a type of marginal zone lymphoma, CD5, CD10 negative. Helicobacter pneumoniae is a milder inflammation. It's longer. My staff say H. pylori look like seagulls. These look corkscrew appearance, may be acquired from domestic animals, especially prevalent in children, less likely to cause lymphoma, both stain with Giemsa, silver, and the same H. pylori stain. And you want to treat with triple therapy, 2 antibiotics, and PPI. Of note, if the patient has a history of treated H. pylori, and they still have H. pylori, sometimes they can be deeper in the glands, so just an FYI. Intestinal spiroketosis, you'll have this fuzzy fringed layer or organisms at the surface. It's not invasive, it's just at the surface. One of my staff likes to call it like a lipstick sign. It'd be like a coat of like kind of thick lipstick. And it's variable species, but most are Brachyspira. Usually there's no associated inflammatory infiltrate, and it stains with your spirochete stains, your silver stains like Worth and Starry and Steiner. The clinical significance is somewhat unclear. Diarrhea is a common symptom, but it's not sure if it's causative or just an associate coincidental. The classic test question will be, the demographics will be men who have HIV. Mycobacterium species. You have M. tuberculosis and you have your non-tuberculosis species, Mycobacterium avium intracellulare complex. I will just call it MAC. You'll have this abundant foamy macrophages in the lamina propria where it's distending the villi. And you can have poorly formed granulomas, usually in immunocompromised patients, classically AIDS patients. You'll have diarrhea, malabsorption, and weight loss, and the organism stained with PAS, like Trophorema whipplei, but it also stains with AFB and phyte. M. tuberculosis, you'll have this necrotizing granulomas that coalesce, and they can have an associated cuff of lymphocytes. The organism stained with AFB and phyte, but culture and/or PCR may be required. Location-wise, in the GI tract, most common in the ileocecum with the sharply defined ulcers and strictures. So in your differential, you want to have Crohn's disease in the back of your head, and it can cause weight loss, fever, abdominal pain, and diarrhea. GI symptoms of note may precede your pulmonary symptoms. Whipple disease caused by Trophorema whipplei, you can have weight loss, diarrhea, arthritis, as well as lymphadenopathy and neuropsychiatric issues and endocarditis. You'll also have this it infects the small bowel, and you'll have this dilation of the lamina propria by the foamy macrophages with variable acute inflammation, and the organism stained with PAS. And you can identify with PCR. However, it's negative for phyte and AFB, differentiating it from MAC. Yersinia, you'll have these abundant epithelioid granulomas with your lymphoid cuffs, and usually not necrotizing. It's a common cause of granulomatous appendicitis. It can closely mimic Crohn's disease. Stains are not helpful, so you want to consider culture, serologies, or PCR to help distinguish it from Crohn's disease. Location-wise, it usually infects the ileum, right colon, and appendix. It can cause ulcers and edema, and it's an infection caused by food contamination, Yersinia. It's a gram-negative Coccobacilliform enteric bacteria. Acute infectious colitis or acute self-limited colitis, this is like the classic symptom of this usually healthy person with just acute onset of diarrhea and abdominal pain that's self-limited and resolves within several weeks. You can discriminate one organism from another, not by histology, but more PCR panel. And some culprits are often foodborne illness, and they include Campylobacter, the most common stool isolate in U.S. Salmonella can cause typhoid fever with hyperplastic Peyer's patches, ulcers, and necrosis with less neutrophils. EHEC, enterohemorrhagic E. coli 0157H7. Shiga-like toxins can cause epithelial and endothelial injury. You can see fibrin thrombi and ischemic changes, and it can cause hemolytic uremic syndrome due to endothelial injury and platelet activation, causing thrombocytopenia, hemolytic anemia, and kidney injury. This can lead to kidney transplants, and just tying it in with blood bank, you also want to think about TTP as your differential or thrombotic thrombocytopenic purpura, where to differentiate it, it's hard to, at least on smears, because both have schistocytes. But EHEC, you can get your PCR panel, and then TTP will have less than 10% Adams TS13 classically. C. difficile, usually after recent antibiotic use, you'll have this watery diarrhea, and you can histologically see the pseudomembranes. And then you have your Shigella and your Yersinia. And then it's important to note that your acute self-limited colitis can be viral in origin, including norovirus, as well as parasites. Sarcina is spherical cells, gram-positive, 2 to 3 micrometers in diameter. They're spherical and occurs in tetrads or packets of 8 or more. It's most commonly found in the stomach. It's unclear if it's pathogenic, and it's likely an incidental finding, usually found in association with delayed gastric emptying and gastric outlet obstruction. So that can prompt a workup to explore the cause of the delayed gastric emptying, and it can lead to discovery of an occult malignancy. Actinomyces, these look like dust bunnies, and they are long filamentous bacteria, frequently seen as incidental bacteria on biopsies or part of mixed flora, colonizing lesions, especially in the oral cavity. It is associated with poor hygiene. It's an uncommon cause of appendicitis, and to tie it in with cytoland, you can see actinomyces in your pap smears as well. It's positive on gram stain and GMS. It's negative on AFB, in contrast to, if I'm not mistaken, Nocardia, which would be positive on AFB, but looks similar to actinomyces. Normal flora, most normal bacteria in the oral cavity intestines are gram-negative anaerobes. On GI biopsies, you'll often see them in the esophagus and intestines. Bacteroides are the most common. Other species include Prevotella and Veillonella. And you can have gram-positive organisms that colonize us, including Streptococcus. Again, these are usually commensal and do not cause disease. However, those that do cause disease can cause periodontal disease that can spread to other regions, leading to endocarditis, abscesses, septic, arthritis, pneumonia. You'll see histologically this polymicrobial clusters, infections highlighted by gram and silver stain. And you shouldn't see abrupt acute inflammation kind of around this normal flora. And histologic findings are generally nonspecific, and further microbiology tests are necessary for identification if warranted. Okay, before we begin on viruses, let's just do a one-liner for bacteria. H. pylori, you can have H. helmanii. Intestinal spirochetosis, look for that fuzzy fringed layer associated with men with HIV. Mycobacterium, MAC, your foamy histiocytes distendovilli, positive for PAS and AFB fight. M. tuberculosis, look for the necrotizing granulomas. Whipple's disease, Trophorema whipple, also distends the villi, but positive for PAS as well, but negative for AFB fight. Yersinia, epithelioid granulomas with this lymphoid cuff. Common cause of granulomatous appendicitis. Acute infectious colitis, get your PCR panel. Sarcina, incidental finding, often in the stomach. Look for those spherical tetrads or packets of 8 or more. Actinomyces, dust bunnies, often incidental. Normal flora are generally gram-negative anaerobes. All right, virus CMV, most common in immunocompromised hosts, especially AIDS, but also you can see them in patients with organ transplant or autoimmune disease on immunosuppressives. Often causes ulcerations. Esophagus, you can get them. You'll have dysphagia, odynophagia, or pain with swallowing. And then stomach, intestines, you can get diarrhea, bloody or watery, and pain. You can see an ulceration endoscopically, and then histologically, you can see the ulcer with mixed inflammatory infiltrate with neutrophils. If they're severely immunocompromised, then you'll have less inflammation. You can see the viral inclusions preferentially, not generally in the epithelium, but in the mesenchymal cells, and most commonly in the endothelium or other stromal cells. In the nucleus, you'll have this owl's eye, Cowdrey A. It'll be pink, nucleolus-like. And of note, Cowdrey A, those bodies can be found in CMV as well as in HSV. And then you have cytoplasmic inclusions, which are granular and pink to purple, Hoff-like. And you want to evaluate closely, especially if this patient has a history of refractory IBD or graft-versus-host disease cases. HSV, this commonly causes ulcerations with variable inflammation. If HSV infection happens in the anal, genital, or anal rectum region, you can get vesicles. You want to look for those 3 M's. Molding, kind of packeted against each other without space. Margination, the chromatin is at the rim of the cell. And multinucleation. And these are at the edge of ulcers in the epithelial cells, in contrast to CMV, which is generally in the mesenchymal cells. It's the number 2 most common cause of infectious esophagitis. It leads to dysphagia. It's self-limited in healthy patients, but it may cause esophageal perforation or dissemination in immunocompromised patients. The findings are the same in HSV type 1 and type 2. Adenovirus. And the normal hosts, it's a common cause of childhood diarrhea. It can cause intussusception due to lymphoid hyperplasia in the bowels. In immunocompromised hosts, you'll have diarrhea potentially leading to disseminated disease, including hepatitis and pneumonitis. This is harder to control. Histologically, you'll have this characteristic smudgy inclusions that are basophilic to eosinophilic. And in the tubular GI tract, you'll have these inclusions in the surface epithelium, often in the goblet cells. They can be round or crescent shaped, and most often in colon with increased apoptosis and epithelial sloughing. Liver, you have your inclusions in the hepatocytes, often at the edges of coagulative necrosis. Fungus, Candida. It's the most common infection of the esophagus. It's more common in immunocompromised, and it presents with dysphagia or odynophagia of the patient, and endoscopically it looks like white plaques with underlying ulcerations. Remember, your white plaque differential includes Candida, granular cell tumor, and glycogenic acanthosis. If you see you can see neutrophilic inflammation with ulceration, but less so if immunocompromised. Parakeratosis is common, and if you're not sure but you're suspecting, get your PAST and GMS stains, and you should see a mix of budding yeast and pseudohyphae. Histologically, a hint will be this kind of on the top of the epithelium, this shredded wheat appearance. Histoplasmosis, this is endemic to Ohio, Missouri, and Mississippi River valleys. It can cause localized or disseminated disease. It's more common in immunocompromised folks. The lung is the most common site, but GI is common too. And in the GI, the most common site is the ileum, and it can present with ulcers or mass. You'll often see histologically this lymphohistiocytic infiltrates without well-formed granulomas. And then they'll be intracellular, 2 to 5 micrometers, and it's positive with GMS and PAS. Histoplasma is intracellular, and it's randomly dispersed within the histiocyte, in contrast to leishmaniasis, although that's more associated with skin. But since we're talking about histoplasmosis, leishmania, you'll have this marquee sign where it'll just be marginating on the periphery, but not in the near the nucleus. Cryptococcus, this is ubiquitous, is often from bird droppings like pigeons, usually in immunocompromised patients, AIDS, organ transplant. It can be localized or disseminated disease. Often common sites are the lung and meninges. You'll have a variable inflammatory response depending on how immunocompromised you are. And you can have granulomas or suppurative necrosis. They're 4 to 7 micrometers, very pleomorphic, meaning like lots of different sizes. As you can see here, this is smaller than this one, which is larger than this one. They have these narrow-based buds in contrast to blastomyces, and they have these refringent capsules which give it a halo or soap bubble appearance when they're unstained. And if you can stain these with GMS and it'll be black. And the capsule stains with mucicarmine. Coccidioides, also known as valley fever, the clinical presentation. It's found in soil in southwestern United States and South and Central America. There's a higher risk if immunocompromised and can have localized or disseminated disease. In the host, the spores develop into these large, thick-walled endospore-containing spherules, which enlarge and rupture. There's often associated granulomatous and chronic inflammation. Okay, just to recap, bacteria H. pylori, H. helmanii, H. pylori can cause malt lymphoma, a type of marginal zone lymphoma. Intestinal spirochetosis, look for that lipstick or fuzzy fringe layer sign. Mycobacterium, MAC, PAS positive, but also AFB fight positive. M. tuberculosis, necrotizing granulomas. Whipple's disease, Trophorema whipple, associated with HLA-B27, positive for PAS, negative for AFB fight. Yersinia, common cause of granulomatous appendicitis, and you'll see these large epithelioid granulomas with this lymphoid cup. Acute infectious colitis. Get your PCR panel. Sarcina, incidental finding, look for those packets of spherules in the stomach. Actinomyces, dust bunnies, positive on gram-stained GMS, negative on AFB. Normal flora. Viruses, CMV, mesenchymal cells, look for those viral inclusions, both nuclear and cytoplasmic. HSV, look for the 3 M's, molding, margination, and multinucleation in the epithelial cells. Adenovirus, in immunocompromised, look for those smudgy inclusions that are basophilic to eosinophilic, can be in the surface epithelium of the GI tract, can also be in the liver. Fungus, Candida, look for the kind of shredded wheat appearance. You can have parakeratosis, neutrophilic inflammation with ulceration, highlighted by PSD and GMS. Histoplasmosis, it's an intracellular organism, and you'll have this lymphohistiocytic infiltrate without well-formed granulomas, positive with GMS and PAS. Cryptococcus, immunocompromised, often from pigeons, and very pleomorphic, kind of look like the soap bubble appearance, and it stains with GMS, and the capsule stains with mucicarmine. Coccidioides, you'll have these thick-walled endospore containing spherules. Okay, parasites. Strongyloides, this is a nematode with worldwide distribution, more common in the tropics and southeastern US. And you get these when you walk barefoot on contaminated soil. It'll penetrate through your skin, goes to the lung, goes to the GI tract, and then out through your feces, and then onto the next host or auto-infect. It's worse in immunocompromised patients. It can be asymptomatic and harbor for greater than 30 years. And when it is symptomatic, you can have diarrhea, abdominal pain, bleeding, and histologically you'll have these inflammation with neutrophils and eosinophils. And it can resemble inflammatory bowel disease. And you want to look for those adult worms, larvae, and eggs, as you can see here, all found in the crypts. Pinworm, or Enterobius vermicularis, spread by the fecal-oral route. Humans are the only host. It's most common in children, often asymptomatic, but can cause anal pruritus as well as incidental, or it can be found in the appendix, and we've had cases where appendicitis is caused by the Enterobius vermicularis. You'll look for the thick cuticle on adult worms, the characteristic lateral spikes, as you can see here. And it has easily visible internal organs, and even invasive worms cause minimal inflammation. Schistosomiasis. This is a parasitic trematode or a fluke. Any species of schistose can be found in the gut. It's endemic to Africa, Asia, and parts of Americas, and the highest prevalence is in sub-Saharan Africa and the Middle East. It's infected by contaminated water, and it goes through the skin. Snails are intermediate hosts. Most patients are asymptomatic but can present with GI bleeding or hematuria if it's in the bladder, or portal hypertension if it's in the biliary tracts. The ova are found in the wall of the GI or GU tract, and they often calcify with time. And you can have variable acute, chronic, or granulomatous inflammation with often prominent eosinophils. Worms often have there's often no reaction. They're found in veins of the bowel or bladder or in liver, and they lay eggs into the urine stool. There are three main species you'll have to know, and because they're often found in humans: the Schistosoma mansoni, usually the GI tract. I think of Charles Manson. He was a famous murderer, so I think of him carrying a knife, and it looks like a lateral spine, as macabre as that sounds. But it helps me remember. Schistosoma japonicum, usually GI tract, and it's just when I say japonicum, I just say Schistosoma japonicum, just very lightly, because it has this very not distinct, not prominent lateral knob, not even a spine. And then Schistosoma hematopium, because it's usually in the GU tract, and it's on the top, or it's a terminal spine. So Schistosoma mansoni, think Charles Manson with the carrying the knife, so it's a lateral spine. Schistosoma japonicum, it's a lateral, just indistinct really, knob. And the Schistosoma hematopium, it's a terminal spine. Okay, liver flukes. The helminths occlude the bile ducts. That lead to dilated ducts with wall thickening, and you can have signs of biliary obstruction, a jaundice, fever, right upper quadrant pain, and it can cause cholangiocarcinoma over time due to the chronic inflammation. Clonorchis sinensis, opisthorsis species, and fasciola species, can be your culprits. They're endemic primarily to Asia and acquired by eating raw or undercooked fish or crawfish. Worms are visible to the naked eye. Echinococcus, cestos or tapeworm, have wide geographic distribution. The definitive hosts are dogs or other carnivores, and humans infected through exposure to feces. The eggs hatch, the larvae travel to liver and form cysts, and the cysts grow very slowly, often asymptomatic, but can get symptoms from mass effect if the cyst grows really large and you treat with surgical resection. Ruptured cysts are very antigenic and can cause anaphylaxis. That's why, just kind of tying it into cytopath, FNAs, this is a contraindication to FNAs if you're going for the liver and there is a cyst, and you're suspecting echinococcus. Histologically, the innermost layer contains protoscolices, which are the developing heads of adult tapeworms, which contains two circles of hooklets and suckers, as you can see here. This is surrounded by a layer of hyalinized, white laminated acellular material. All right, last but not least, I hope you're hanging in there because we're almost there, done. Protozoans, Entamoeba histolytica. Protozoans most common in subtropical and tropical regions, and U.S. is most common in immigrants and travelers. You get infection through the fecal-oral route and contaminated food, water. It can be asymptomatic, but if you are symptomatic, it can cause variably severe diarrhea. It can also cause this amoebic liver abscesses that look like anchovy paste. And histologically, it causes this deep flask-shaped ulcers extending into the submucosa and undermining the nearby mucosa. Architectural distortion may mimic IBD, and you'll have this often abundant amorphous eosinophilic debris. Entamoeba has this round red eccentric nucleus, and with distinct cell membranes with foamy cytoplasm and having ingested red blood cells. Giardia duodenales, it's the most common protozoa infection in the US, usually acquired from contaminated water. Usually the test question will be a hiker who drinks some spring water. And it's more common in kids, those with travel history and those immunocompromised. It causes diarrhea, often foul smelling, can be chronic, especially if immunocompromised. You usually see trophozoites with no associated inflammation. Sometimes you can get mild villus blunting and chronic inflammation, but you want to look for that fallen leaf signs from the lateral view. And then if you're lucky enough, you can kind of see this kind of bird's eye view and see this pear-shaped with two oval nuclei. And the organisms of note, they stain with CD117 or c-Kit. And when you do see Giardia, you just want to look at the lamina propria to see if they're plasma cells, because if they're not, you want to also think about like CVID, or common variable immunodeficiency. Cryptosporidia, this is an obligate intracellular worldwide parasite. It can be acquired from contaminated water or person to person. Diarrhea is a symptom that's self-limited in normal hosts, but often chronic, relapsing with weight loss and cramping in immunocompromised. There's no really good therapy. Histologically, the parasites appear as 2 to 5 micrometer basophilic blue beads on the luminal apical surface. You can see villus blunting and variable inflammatory infiltrate, and it's enveloped by microvilli, and so there's less microvilli for absorption later on, and you can get diarrhea. Cyst isospora, these are obligate intracellular worldwide parasites. It's also, you get acquired by contaminated food and water. It causes diarrhea, often chronic, and can be debilitating if you are immunocompromised. You'll have this villus blunting with mixed inflammation and prominent eosinophils. There are variable forms, but all are intraepithelial, in contrast to Cryptosporidia, where they're on the lumina surface. Some are crescent shaped, some are banana shaped, others are round with prominent nucleoli. And then last but not least, you have Cyclospora, which also is a protozoan with worldwide distribution that causes diarrhea. Infection occurs through contaminated food and water. You'll have variable villus blunting and inflammation. You'll have these round 2 to 3 micrometer forms and crescenteric merozoites, 5 to 6 micrometers in parasitophorous vacuoles, as you can see here. And Microsporidia, this is a fungus that causes intestinal infection, particularly in AIDS patients, and leading to diarrhea. You'll have these small spores, 2 to 3 micrometers, and larger plasmodia. And it's located within supranuclear cytoplasm of epithelial cells. So, thank you so much if you followed me through this journey of Kurt's notes of GI infections. And last but not least, let's do our one-liners. Bacteria, Helicobacter, H. pylori, H. helmanii. Former is associated with multiple lymphoma. Look for that chronic active gastritis with superficial lymphoplasmacytic infiltrate. Intestinal spirochetosis, look for that fuzzy fringed layer. If you're not sure, get your Warthin Starry Steiner spirochete stain. MAC, usually immunocompromised, abundant foamy macrophages, distending the villi, positive for PAS along with Whipple disease, but this is all positive for AFB fight. M. tuberculosis, necrotizing caseating granulomas, Whipple disease, positive for PAS but negative for AFP fight. Yersinia, common cause of granulomatous appendicitis, abundant epithelioid granulomas with lymphoid cuffs, acute infectious colitis, get your PCR panel. Sarcina, it's often incidental but associated with gastric outlet obstruction. Your tetrads or packet of 8 spherical gram-positive cocci. Actinomyces, long filamentous bacteria, often incidental, positive on gram-stained GMS, negative on AFB, normal flora. Viruses, look in the stromal cells for CMV. They can have nuclear inclusions and cytoplasmic inclusions. And be sure to evaluate for refractory IBD and graft-versus-host disease cases. HSV, look in the epithelium for molding, margination, and multinucleation. Adenovirus, for healthy hosts, just childhood diarrhea in kids, and immunocompromised host diarrhea, potentially leading to disseminated disease. You'll see these characteristic smudgy inclusions that are basophilic to eosinophilic. It can be in the tubular GI tract, in the surface epithelium, often in goblet cells, also in liver, as well as lung. Fungus, white plaques endoscopically, neutrophilic inflammation with ulceration, shredded wheat sign, get your PASD and GMS. Histoplasmosis, Ohio, Missouri, Mississippi River valleys, lymphohistiocytic infiltrates without well-formed granulomas, intracellular, in contrast to, and dispersed within the cell, in contrast to leishmania, which is just kind of marginating in the periphery. Cryptococcus, very pleomorphic, lots of different sizes. Look for your soap bubble appearance. You can stain with GMS. Coccidioides, valley fever, thick-walled endospore containing spherules. Parasites, strongyloides, it's nematode, worse in immunocompromised patients, can be asymptomatic. Look for the worm, larvae, and eggs, all found in the crypts. Enterobius vermicularis, pinworm, most commonly seen in the appendix. Look for the characteristic lateral spikes. Schistosomiasis can be in the bladder, can be in the GI, can be in the biliary tract. For the worms, often no reaction to them, found in veins. And then the ova, found in the wall of the GI or GU tract, and they often calcify over time. You can get variable acute, chronic, or granulomatous inflammation, and often prominent eosinophils. 3 types. Remember, if you ever see the egg, it's on a test question. Schistosoma mansoni, GI tract with the knife, carrying the knife, so it's a lateral spine. Schistosoma japonica, usually GI tract, it's a lateral knob, not very prominent. And schistosoma hematopium, GU tract, terminal spine. Liver flukes, signs of biliary, can lead to biliary obstruction and risk factor for cholangiocarcinoma. Canorchis sinensis, Opistorchis, and Fasciola species. Worms often visible to naked eye. Echinococcus, a tapeworm. A definitive host is dogs, and they can form cysts. Cysts grow very slowly and can get symptoms from Mass Effect, and it's very antigenic and can cause anaphylaxis. Look for your circle of hooklets and suckers. Protozoans, Entamoeba histolytica. Look for your deep flash-shaped ulcers. You can get liver abscesses as well. Histologically, you'll have round red eccentric nucleus, distinct cell membranes with foamy cytoplasm and with ingested red blood cells. Giardia duodenalis. Look for your falling leaf signs on the duodenum, often no associated inflammation. Once you find them, think about CVID with the lack of plasma cells, and they stain with CD117 or c-KIT. Cryptosporidia, look for your 2 to 5 micron basophilic blue beads. Cyst isospora, all intraepithelial, some crescent, banana-shaped, others are round with prominent nucleoli. And then you have your cyclospora and microsporidia. Cyclospora, also around 2 to 3 micrometer forms, and crescenteric merozoates, and microsporidia. All right, thank you so much for watching. We hope to see you in the new year, and take care. And until next time.